Morning, everybody. I'm Nick Wareham. I am just waiting to get the nod that we have stopped admitting people. I think we have some people just joining. So, um, if it's okay, are going to push on. So this morning, it's great that we've got Michaela van der Schaar, who's going to speak to us as Cambridge Public Health. So this topic, AI, causal AI for real world public health decisions, is one of the priority areas for Cambridge Public Health in terms of sparking conversations. So that's hopefully what we're going to do this morning. So Michaela is the John Humphrey Plummer Professor of Machine Learning, Artificial Intelligence and Medicine, and she has a vast experience of this topic, and it's a great privilege for us to have her speak to us this morning. So over to you. We're going to leave time at the end for Q&A. Hopefully, Michaela, you're going to speak for like 40 minutes or so, 45, and then we've got 15 minutes for Q&A.
Thank you very much, Nick, for the kind introduction, and thank you everyone for being here. I'm going to do something very naughty. I promised to you to talk about one topic, but I'm going to talk about slightly another. It will still be related to causality, but I thought that this topic will be a little bit more interesting and pertinent, but I'm very happy to come again if you still are okay to have me to talk about the original topic. Causal AI. But before I go there, I want to say that if you are interested to learn more about what we do in machine learning for healthcare, we have as Cambridge Center for AI in Medicine two summer schools. One is the Machine Learning for Healthcare Summer School, which is really aimed at people who have quite some background in machine learning, but would like to really go at the cutting edge of what is happening in machine learning today, and especially machine learning for healthcare. And the second one is a Clinical AI Summer School, more targeting clinicians who have some familiarity, but much less familiarity with AI. And we would like to, again, introduce what type of tools currently exist throughout the world and what clinical AI nowadays is. So please join us if you are interested in any of these two. Okay, without further ado, what I'm going to talk about today, I will focus on two connected ideas, but the first one will be very brief. I'm going to talk about a 10-year-long journey of my lab in building causal inference methods using machine learning, and how we can move beyond prediction and estimate what would happen under different interventions. And I will give you a brief overview, and if any of these topics or subtopics is interesting to you, I'm very keen to come again and talk about that. But the main part of the talk today will be about AI-enabled digital twins, which is, if you like, a sister topic, but the one that I decided to focus in the hope that I can find among you collaborators that are interested to build such AI-enabled digital twins. And the reason I want to focus on this is because here is where causal reasoning truly becomes, in my opinion, actionable. Because as you are going to be able to see, we can simulate possible futures, we can evaluate alternative policies, we can support real decisions in public health and medicine. And I hope that the overall message of this talk is that causal AI will help us understand interventions of all different types. And digital twin helps us use that understanding to decide what to do. Okay, so as I mentioned, this work started in my lab on causal AI around 10 years ago, maybe slightly longer than that. And it has been a long journey. I became familiar with this topic early on. I was a professor at UCLA prior to moving to the UK, and one of my colleagues was Judea Pearl. So the initial, let's say, touch with this topic came from there of machine learning. But it's interesting, I started to be super interested in doing work in causal AI, not because of the machine learners and computer scientists, but rather because of the statisticians. So I saw amazing work happening in statistics and econometrics in this area of causal inference. And I felt that machine learning could really help take these methods, make them even more powerful, dealing with more complex data sets. And the initial part of my work was very much trying to take powerful statistical and econometrics ideas in causal inference and make them more powerful using machine learning. So what can causal AI do? And you see here a variety of topics, and my group has worked on all of them. So if you are interested in one of them, I'm keen to come back and talk more about that. One is about estimating treatment effects, and do that not only for a population, but also for different groups and subgroups. One of the most interesting components is vulnerable groups, for instance, and trying to really understand the effect of that. Then going, if you like, from the top down, a lot of work happened in our lab and is still happening on pharmacology. So really trying to understand causal effects that could be interested to determine optimal dose for individuals. Then another thing is guiding treatment choice when the standard of care is absent. So very often, as you know, a standard of care may exist, but there may be either because of the heterogeneity of the disease of the patients, or at times after the first standard of care doesn't work, we are left with really trying to estimate what is the best type of choice that we can make for a particular patient or subgroup. And here is again where causal AI and causal inference can be very helpful. Another one is designing treatment effect recommendations, including in settings where we have more than one treatment. In the most recent years, in the last 5 years, we have been interested not only to do that for causal effect inference based on cross-sectional data, but also on longitudinal data, looking at medium and long-term outcomes as well. So learning from electronic health record data or registries from longitudinal data and trying to estimate treatment effects in subgroups on the basis of longitudinal information. Also, what is interesting is estimating post-approval efficacy. So, for instance, using that after a particular drug has been approved, trying to really understand effects of different types of treatments for different subpopulations. And last but not least, causal AI plays a very important role in treatment, randomized controlled trials, both in determining within the different stages of the trial, and especially in phase 2 and 3, understanding either dose for subgroups, understanding potentially what treatments and what sub-treatments could be useful. So usually this is what we think when we think about causal AI. And as I mentioned, we are trying to learn from observational data. A good example is electronic health record data. And this data is, of course, biased by the clinical practice, current clinical practice. So that makes causal inference challenging. And also at times we don't overlap. Not all the patients are treated or untreated with a particular type of treatment, and hence that leads to additional challenges. So if you are interested to see more what we have done for 10 plus years, we have a website where most of this work is accumulated. And just to highlight some of the earlier work that has happened in the lab that got, let's say, translated to something practical. So first is the use of these causal effect methods for estimating individualized treatment effects and especially precision dosing. So how can we do quantitative models in pharmacology, and how can we really use machine learning to estimate the effect of particular types of dose on individual patients. And then more recently, together with collaborators and a few of my students, we wrote a paper that appeared in Nature Medicine where we kind of summarize where we are today with this field. And I think that this is really quite far. These methods tend to be quite robust and powerful. But causality is essential, but it's not enough. So the reason I today decide to talk about something different is kind of what I feel as a next step in making these causal methods more pertinent and more useful for public health and medicine is the fact that while causal AI can help us estimate what would happen under different interventions, and this is wonderful, even if we had perfect causal estimates, we still face a harder question. What should we actually do in terms of interventions? So, for instance, in a real public health and clinical decision making setting, we have different actions that in the end compete with each other. Also, we have resources that may be limited. We may have different types of objectives which may conflict. The timing may matter, and uncertainty is always present in these methods. So, the real decision problem is not only what is the effect of an intervention, which is the study of causal AI and the work that I used to be doing in the past, but the question really is for you, the clinicians and the public health researchers, is which action should we take for this individual or for this population or subpopulation at this particular time under these constraints to achieve this objective we care about. So this motivates the move from causal estimation to digital twins as a way of, let's say, thinking about real world decision making. So this is why today I decided to talk about digital twins. You heard a lot about digital twins, I'm sure, and I will make the link to causality in a little bit, because in my mind, a digital twin is a causal adaptive model of an individual system. And its value is not simply that it predicts the future, but rather it lets us simulate possible futures under different actions. So we don't have here prediction, we don't have here causality and causal estimation, we have something even more powerful. We have this ability to generate possible futures under different types of actions. And this is crucial for real world decision making in my mind, because we can use digital twins to ask what might happen if we intervene earlier, or choose a different treatment, or allocate resources differently, or change a public health policy. So the move here is from estimating effects in causal effect inference to this time the focus is not just estimating effects, but rather generating possible likely futures and choosing among them actions over time. So these digital twins give us, if you like, a way to evaluate policies before deployment and reason under constraints and uncertainty. Okay. So here is a definition from the National Academy of Science in the United States, which defines a digital twin as a virtual representation of a real system that captures structure, context, and behavior, and it updates with data from the physical system, has predictive and generative capability, and informed decisions that create value. Now, the important point is that a digital twin is not just a static model or a dashboard or a predictive model. It is a living model of a system that can be updated as new data arrives. New data for the patient, or new data for a healthcare system, or for instance, a new intervention like a new medication. And you will see examples of this. And to build sorry, maybe I should stay here a bit more. So to build such a twin, we need to combine real-time data, prior knowledge if we have, and you will see examples of that. It could be, for instance, physiological knowledge and machine learning. And this combination will allow us not only to mirror the real world, but also to simulate, and the word is simulate, how it will respond under different interventions of policies. So unlike in causal AI, where we are just focusing on estimating the effect of an intervention, here we are going to be able to simulate possible futures under different interventions of policies. Okay, sorry. Okay, so what type of digital twins? Of an individual patient, of an organ, of a tumor, but why not, and more pertinent to the discussion today in public health, an entire healthcare system, a hospital, a clinic, an entire country. the NHS system, or a clinical trial. But I just want to make a parenthesis here and say that digital twins, of course, are useful in many other settings, and that there are challenges associated with building digital twins for a particular setting. Today, I'm going to focus, of course, in medicine. And I'm going to say that the reason I started to be increasingly interested to move from causal AI and bring causality to digital twins is because I really feel that in order to empower public health researchers and clinicians to really think about interventions, digital twins is a very powerful way to test hypotheses, to think about hypotheses, and to make then decisions on the basis of that are timely. So the key idea here is that digital twins are not predictive models. So we are not only making predictions, we do something that it's a lot more powerful and a lot more challenging from a machine learning point of view. We are generating models of individual patients. We are not only predicting the most likely future, these digital twins allow us to simulate, to generate different possible futures under different actions or interventions. And this matters because clinical and public health decisions are rarely static, and we need to understand complex patient journeys, test hypotheses safely, and compare alternative intervention strategies before acting. So just to give an example, we might ask how a patient's condition could evolve under different therapies, whether stopping treatment could help create rebound risk, or whether earlier versus later intervention could lead to better outcomes. And you can do that at the patient level, you can do that at the clinical trial level, you can do that at the healthcare system level. So digital twins in a nutshell help us reason about possibilities, not only just what will happen, but what could happen if we act differently. So we see here the causality notion. So this is why I'm so interested in building digital twin. I hope I excite a few of you because it enables us to reason about possibilities. And this is what good public health clinicians do. They imagine what could happen, they go through this reasoning process, and then they make judicious decisions. And digital twins could empower such specialists and such researchers to think about the likely possibilities and reason about them very quantitatively in a data-driven way using prior knowledge they may have as well as machine learning. Very small parenthesis here. Many of you know that, again, around 10 years ago in my lab, our lab really started this idea that's now very popular of synthetic data, and we did a lot of work on synthetic data. But digital twins are not just synthetic data. And this may be clear to most of you, but occasionally I get people confusing the two. Digital twins are not the same as synthetic data, even though both of them are generative kind of ideas. There are similarities, so both can simulate and represent aspects of real data are generative rather than predictive models. Both can help with privacy, accessibility, and decision support, but really their purpose is different. For synthetic data, we usually generate a data set, and it is often a generation that is done once, and then we use it for analysis or model development. But a digital twin is different. It is an individualized, adaptive model of a real system. So, for example, a patient or a healthcare system or a trial. And it is meant to evolve as new data arrives, and crucially, to simulate interventions. So the key distinction is that synthetic data helps us create data-like examples, while digital twins helps us reason about what could happen at this moment in time or in the future under different actions. Okay. Now, let us start with some first work that started in our lab, and this work is quite general, so I'm going to present it in its specificity, but it's quite general, and I hope I can present why it's so general. So the idea here is that at times you may have prior knowledge. This knowledge may come from physiology, may come from pharmacology, and I work with a lot of pharmacologists, so you will see that a lot of the work that we have in this paper is for pharmacology, but it could be from any domain where you have some prior knowledge. And then you have this prior knowledge, which then you embed using a machine learning model that you are going to see in a little bit is a large language model based machine learning model to build these digital twins. And I think this is very powerful. And I hope many people who have interest in building digital twins and they have specific know-how from medicine, from public health, from physiology, will work with us to develop that. So the motivation in this initial work is that digital twin need both structure and flexibility. And mechanistic models, such as physiology, pharmacology, give us scientific structure and interpretability, while more general machine learning models, whether it's neural networks, whether it's large language models, can capture more complex pattern in the data, thereby individualizing this. So let us look at how we did this. So first we model patients, or for that matter, a system that could be a clinical trial or a healthcare system. And of course, the more complex the dynamical system, the more complex the underlying variables and dynamics that need to be captured. I'm showing here something a little bit simpler just for the sake of representation, but there is nothing stopping this framework to be more complex. So keep in mind, in this case, maybe a patient physiology or disease progression or tumor growth or infection dynamics or response to treatment. And in this dynamical system, there are three ingredients. First, what we call the state space. And these are variables that describe the system at a given time. Example, biomarkers, symptoms, clinical measurements. Second, we have the action space. These are the interventions we can apply, treatments, policies, changes in care. And third is the dynamics function. And this is the rule that describes how the state changes over time in response to those actions. And this formalism is important because it gives us a language for the digital twin. So it can model the dynamics. So if we can model these dynamics well, then we can simulate what may happen next under different interventions, and we can use this for decision support. So dynamical systems are not some abstract mathematical idea. They are really everywhere in medicine and healthcare. A good example, and I put at the bottom, could be a disease evolving over time, a treatment may change in the trajectory, the physiology responding dynamically, but also public health systems evolve. Infection spread and interventions alter behavior. So for instance, an SCIR model, a PKPD model, a tumor growth model, all show different type of structure, which is really the state of the system. There are interventions or actions, and there are dynamics that determine how this state changes over time. Now, a digital twin is essentially a model of these dynamics, allowing us to simulate how the system evolves under different actions. Now, let me connect this idea of a dynamical system to that of a digital twin and see why one is a subcomponent of another. So a digital twin is a computational generative model that tries to approximate the true dynamics of a real system. In other words, it learns how the system may evolve over time in response to actions. And once we have such a twin, we can ask all sorts of interesting questions, much more complex questions than just simple prediction. We can simulate future outcomes and likely future outcomes, not just the highest probability of something happening, but a variety of possibilities. We can understand how the system may change in different contexts. We can evaluate the alternative interventions of policies. And I think that in public health, this is, I think, powerful because we can ask how might disease spread evolve? What might different groups respond differently? But the challenge here is that a digital twin should not only perform well on the kinds of patient settings or intervention it has seen during training, it must also be able to reason about state action distributions that are not well represented in the original data. And this is really quite important in medicine and public health because the world is heterogeneous. The patients differ, the populations different, the interventions that may be deployed in different settings may not be identical to the training data. So, for instance, a digital twin may be trained on adult population, but the question will be, can this data help us reason about the pediatric patients, just to mention something? Or it has been seen one treatment regime. Can we say something about a slightly different clinical context? A second challenge is that in many healthcare and public health settings, we do not have very large data sets. In some we may, but in many we don't. And this is especially true if we have rare disease or new treatments or specific subgroups or rapidly evolving clinical situations like we had in COVID, for instance. And in this case, a useful digital twin needs to learn accurate dynamics from limited empirical data. It cannot rely on huge, massive data sets availability. And then finally, a digital twin should not be fixed forever at the moment it is built. Real world systems change, new treatments appear, new pathogens evolve, but also the guidelines may be updated and maybe even new types of measurements because we have new technology may become available. So these digital twins might be easy to update as the system changes without needing to rebuild or retrain everything from scratch. So just to take an example, if we have bacterial evolution or antimicrobial resistance, if such a new strain emerges or if resistant patterns change, can the digital twin incorporate this quickly and support future decisions? Now, there are two main ways that people have looked at building digital twins over time. The first type was more mechanistic in nature, and these models are grounded in scientific or biological knowledge, often through equations. So again, I work with quite a lot of pharmacologists, and so they are doing this a lot, but I know that in public health, you are doing that a lot as well. And this is, of course, very powerful because when the assumptions are indeed correct and these models are correct and not misspecified, they can generalize well and are very interpretable. But the reality is that there are also settings in which they can fail badly if these equations are incomplete or wrong, and they are often difficult to update when the system changes. Also, they are not very easy to personalize to groups, subgroups, or specific situations. The second type of modeling is completely neural, and these models can learn dynamics directly from data and can capture complex patterns that are hard to write down mechanistically. But the disadvantage of these models is that they require quite a lot of data. Many of them are black box, and they are not easy to modify once trained. So the challenge we faced when we looked at the prior work a few years back is that neither approach alone seemed at the time to allow for generalization, sample efficiency, and evolvability. So we needed the strengths of both. And this is why we created hybrid digital twin, where the idea was to combine the strengths of the mechanistic and the neural modeling. And the mechanistic component will bring the domain knowledge and structure and can help with generalization, while the neural component can capture complex temporal patterns that the mechanistic model may miss or that are difficult to specify by hand. And again, this concept here is very powerful. If you have some prior knowledge that can be represented somehow, you can then combine it and hybridize it with a neural model. And our goal was to automate this process and to build a very general way of building such hybrid twins where we have prior knowledge, mechanistic knowledge, and a neural component. And what we decided was to use large language models to help specify and optimize this hybrid digital twin. If you look even earlier in the past, we used to be doing neural networks ourselves, and we used to build a lot of neural ODEs and hybrid digital twins in that way. But here we wanted to be more general and use large language models to help specify and optimize these hybrid digital twins, such that we can build models that are more accurate and more adaptable and less dependent on specific knowledge of neural networks. So let us talk briefly about the idea, and then I'm going to illustrate it. So the key idea is that we are using large language models not just as text generations, like you usually see them in practice when you are interfacing with a model such as Claude or GPT, but rather to use large language models as model designers. So the LLM will propose candidate digital twin specifications represented in the form of code. Then the model parameters are optimized using the training data, and the candidate twin is evaluated automatically. And the evaluation results are fed back to a large language model, which uses them to propose improved versions. And in this way, we are going to create what I call an evolutionary loop. We generate a candidate model, fit it to data, evaluate it, improve it over multiple generations. So the aim is here to make hybrid digital twins construction more scalable. So let's look briefly at this diagram, which illustrates kind of the basic intuition behind our approach. So if you start at the top left corner, we start with the data from the system we want to model, together with any requirements that could be given in natural language, or prior knowledge that we want digital twin to respect. This could come from mechanistic models, it could come from papers. And then we ask a human expert to manually design rather than asking the human to design this manually, like would have happened in the past. We use a large language model to take the specification and the data to propose a candidate model structure. And this structure can combine these mechanistic components, this prior domain knowledge, with flexibly learned components, which can capture patterns in the data. And again, the important point is that this large language model is not replacing evaluation. Each proposed model still needs to be fitted to the data and tested. And this is what you see in the lower part, where each proposed model still will need to pass through this evaluation process, because the large language model will help generate candidate structures, but the empirical performance is what determines which candidates that the large language model has provided survive and are improved. So this is a iterative way of using large language models and data to design increasingly better digital twins. So let us zoom in. What really this large language model generation for digital twins look like? So we start with the ingredients that a human modeler would normally use: data from the system, system requirements, prior knowledge about the system, which this digital twin should capture. And the key question is, can we move from these inputs to this hybrid model in an automated way? And the answer is yes. The LLM will be used as a model generator that takes these inputs, and rather than asking it to simply make prediction, we ask it to propose a candidate hybrid digital twin. Hybrid because it uses this prior knowledge. And this will be expressed as code. And this is important because the output is not just text. It is an executable model structure that can be trained and then evaluated. And once this first candidate model has been generated, we fit its parameters using the available data and then evaluate it. And the evaluation error gives us a concrete signal of the model quality. So the large language model proposal is not accepted blindly. We don't accept it crazy proposals, but it is rather tested against its empirical performance on the data that we do have. Then the evaluation is fed back into the process. The large language model sees the previous model and its validation performance and uses its feedback to propose a new candidate. And this is where the iterative improvement begins, because the system can learn from what did not work well and try alternative structures. And by repeating these loops, we get an evolutionary model which generates, optimizes, evaluates, but also refines these models. And over multiple generations, the framework searches for hybrid digital twins that better and better combine the available mechanistic structure with this data-driven flexibility. Now, after we went from several generations, at each stage, the framework is no longer starting from scratch. It uses what it learned from the previous candidates and its evaluation error to generate a better and better hybrid digital twin. Okay, and we can see that as the new generation improves, the validation error will also improve. And this is the essence of this evolutionary process, where each round gives the system feedback, which then the large language model uses and internalizes this feedback to search for more effective model structure. So that these agents, if you like, these large language models agents can help automate the construction of hybrid digital twin, but only when embedded in a rigorous loop of proposal, generation, parameter fitting, empirical validation. Okay. So after many generations, we can decide that the model is good enough. How do we do that? It could be either that a certain number of predetermined generation is finished, so a certain computational budget is achieved, or that the validation error is below a certain threshold. Kind of the key point here is that the LLM is not being used in an unconstrained way. It explores possible model structures, and the empirical validation determines whether a model is actually better and it's subsequently evolved and how. So the contribution here is a disciplined way of automating this hybrid digital twin construction. So let us see how well this works. So first we examine evolvability, and we start this with this, if you like, equation if we have a mechanistic model, and then we keep on evolving it over multiple iterations. And initially it may be just a more and more sophisticated mechanistic model, but as time goes by, we are able actually to add additional components. We may add neural components associated with it to further refine it. And you see that the validation error on the holdout data is really improving for some time. But then suddenly what we see here is that a new kind of variant of this digital twin is created, which again decreases the performance. In which case, we decide not to evolve it further, but to take a previously evolved digital twin further. So in this way, we are able, if you like, to operate on the Pareto frontier and make sure that we are really improving and self-improving only the very best candidates while discarding the other ones. What's also interesting here is that we can add expert feedback. So because the hybrid digital twin is represented in a more modular and interpretable way, and this code is very readable, the experts can guide how the model should change. And this can be done at any step. And this is very different from a purely black box neural model, where incorporating expert feedback will not be possible. Or it will be possible only by doing complete retraining. So the key point here is that, again, for something like public health and medicine, expert knowledge may be evolving, and a useful digital twin must be able to absorb that knowledge to become better over time. So you can do that both during the training process, but you can also use it to retrain the digital twin if new information becomes available. Now, let's take another concrete example of evolvability, adapting this digital twin to an intervention that it has not seen before. So for instance, let's take an example that we took here on COVID-19, and changing public health setting, new interventions may appear, or existing interventions may be deployed in a new way. And then a useful digital twin should not require this complete retraining, but rather, because this hybrid digital twin is symbolic code-based representation, it can make targeted changes to the relevant parameters and mechanism, and this is easy to kind of incorporate. So evolvability here is key. What, in terms of accuracy, we ask a very basic question, kind of if the digital twin is tested on in-distribution data, settings similar to those we have seen into training, does it simulate things that we have seen accurately? And you see here that the results are encouraging because the hybrid digital twin achieves lower simulation error than purely neural or purely mechanistic models. So this idea of hybridization, where we take domain grounding components that give useful structure, but also data-driven components that capture patterns that mechanistic models may have missed, seems to be very powerful. What's also even more exciting is that for out of distribution settings, these hybrid digital twins seem to outperform either purely mechanistic models or purely neural models. And the reason why we believe this is the case is because the neurosymbolic structure helps the model generalize, and the symbolic component provides domain-grounded structure, while the neural component will capture patterns that a mechanistic model may not. So wonderful. This is, if you like, our hybrid model. But this model has some challenges. For them to be really useful, we really need personalization of the individual of the system, as well as adaptation as this new information arises. And we would like to do that continuously. And that may not always be very possible in the example that we just described. So what we wanted to see is that can we build a completely large language based model that is able to continuously update this digital twin using just large language models and no longer have a mechanistic component. So the answer is yes in this paper called CanDT. And the challenge that we needed to overcome in order to be able to do that was that we have a vast state action space, and that can place large data burdens on building a digital twin. And this is especially complicated now because we don't have a mechanistic model that can encapsulate these dynamics. But instead, the large language model will need to deal with that. And we know that large language models have a limited context window, and they can poorly perform and overload it. So a naive large language model based digital twin may not work well. So to combat this with, for instance, reg style retrieval of relevant data is difficult because this time series data that the digital twins operate on is out of distribution for typical pre-trained encoders. So these are, if you like, the challenges that we really want to kind of overcome. So what is really our core idea? The idea is to use flexibility of large language models, but also in-context learning to make digital twins more adaptive. So rather than requiring the whole model to be redesigned every time a new variable or a new treatment or a piece of knowledge appears, this model CanDT changes just the context used of the model. It brings the relevant patient history or similar trajectory or clinical knowledge or candidate actions that are most relevant and uses this to simulate the next possible states. And this is important because the clinical landscape, as we discussed before, evolves, and a digital twin should be able to incorporate this new information. So the important message here is that CanDT is not simply prompting an LLM and asking what will happen next. It is rather a structured digital twin-based simulation framework, which uses an LLM. And at each step, the system will decide what information is relevant. For instance, what part of the patient history, what variables are relevant, what clinical knowledge or guidelines are relevant, what actions are relevant, and selects then the context that is more useful for the current simulation state, rather than overloading the large language model with everything. And on the basis of this, then the next state is generated conditioned on this information. And as the simulated trajectory unfolds, the context can be updated again. So the model is not static. It adapts on the basis of the information. And you can see how this is becoming now very natural and easy to do with somebody that has clinical or public health policy knowledge. And the empirical results show two main points. First, that CalmDT performs competitively as a digital twin. And you have here two examples, one in cystic fibrosis, one is on lung cancer progression tasks. And what you also see is that the performance depends on how intelligently we choose the in-context information. So this is really, really quite important. And to kind of make this point even closer, what I want to show in this example is that CalmDT performs competitively across these two settings, but if we are adding increasingly more and more information, what happens is that when we retrieve these relevant patient trajectories, we add trajectory summaries, and then we use stronger LLM benchmarks, performance improves. But this improves with a few context samples, then saturates, as you see here. And then as the more context is added, it's not always getting better. So we need to learn indeed, and this is what CalmDT does. It uses what makes for the right context, and this is selected adaptively to support this accurate simulation. So kind of the unique sources exactly determine the relevant minimum context necessary for the simulation. So finally, we are addressing what you see here again is that, again, as new treatments appear, new evidence becomes more and more powerful and updated, the variables we care about may change. And then we can ask CalmDT when it should adapt. And what this table is showing here is increasing performance with updates. And what happens if we add only the new action? And the model is told that, for instance, in this case, because it's cystic fibrosis, a new drug, ivacaftor, exists as a cystic fibrotic treatment. This already allows simulation, but performance is weakest. If, on the other hand, on the second row, we add knowledge about the treatment, for instance, in this case, we added a natural language description talking about the clinical trial, and when this clinical trial show results and performance improvements, you see that the performance of the digital twin improves further. In other words, that mean square error goes lower. And then in the third example, we put even more knowledge. We add example trajectories from patients that were treated with ivacaftor in the context. And in this case, the model has both the clinical knowledge and the data-driven examples, and the performance gets even better. So kind of the takeaway here is that CalmDT can incorporate new actions, new knowledge, and new data at simulation time. And it does not require the digital twin to be rebuilt from scratch. But how we add this relevant information matters. Finally, and I realize that I really need to stop soon such that you have time to ask questions. We also very recently improved this model and built what we call decision theoretic digital twins. And what is important here is that we not only have the more data, the better. So a question that we always get is, how much data do I need in order to have a high quality digital twin? And what we show here is that depending on your decision, the amount of data you need may differ. So what is really the key insight here is that the small transition error can accumulate or matter differently depending on the type of policy that you may need. So we need to build a digital twin that's just good enough to allow us to rank correctly the policies and help with decision making. We don't need to build the world's best digital twin, but just one that's good enough to help with decisions. If you want to read more about digital twins, the work that we are doing on these digital twins, you can read more about it on this website that we put together that contains both some more general articles as well as some of our large language models based digital twins that I described here. Thank you.
Great. Thank you very much, Mihaela. That was terrific. Really great talk. And I'm sure it'll generate lots of questions in the Q&A, but maybe I'll start with two that are already there. Um, uh, Somebody asked a question about the relationship between digital twins and clinical trials. Would you like to address
Yes,
that?
I would like very much to talk about that. So, I've wrote quite a lot actually about this topic. So, please either take a look at our website. So we have recently put a website about our work on clinical trials, and you will see there a subsection about digital twins. So, how can digital twins help clinical trials? They can help many of the stages of the clinical trials. First, by running digital twins, it can help us understand who we should recruit and maybe at what point in their disease they make good recruits for a particular clinical trial. So it can help with recruitment. It could also help by running synthetic control arms. So we know that in many settings, we would like maybe because of the disease and because of the acuteness of the disease, it will be almost unethical not to give people the treatment if we have something. So in that case, running digital twins as the synthetic control arm could be a solution. So this is just two different ways, but there are many other ways in which digital twins could be useful for clinical trials. And I'm very excited about this topic.
So the next question, I guess, is from someone who is a student in healthcare, who is asking whether this topic is solely the province of computer scientists, and if not, how does someone like that get involved in it?
Thank you so much for this question. So first, if you would have asked me 1 year ago, I would have said yes, most of my lab is computational and has only a computational background. But since last year, I have two PhD students in my lab. One is a fully qualified clinical doctor who also knows a lot about machine learning, but he's a fully qualified clinical doctor from Australia. The second one is a current medical student in Cambridge. So not everybody in my lab has the background, but this is more for us who are trying really to build these cutting edge machine learning methods. What if you are interested to learn more both about machine learning? This is why at the beginning of my talk I advertised the summer schools. We have two summer schools. They are very low cost, especially for students, and also we have many people who are sponsored. So please apply and take a look. So again, two summer schools. One is more geeky, one is more targeting clinicians with lesser knowledge of machine learning. So please take a look and decide which one is the most relevant for you. And number three, I really feel that this large language model revolution made the barrier to entry very low. So I think even if you do not know, this is why I wanted to highlight these two works based on large language models. So if you look at earlier work from our lab, it was a lot more mathematical, a lot more sophisticated, but now we don't really need that. We are surprised to see how amazing these large language models are in creating code that it is very executable without you even needing really to look through it. So what you can do is you can use your medical knowledge or public health knowledge to evolve these digital twins. You can also interject if you don't like what's happening. So you can generate, let's say, digital twins for patient or or groups of interventions, see what's happening, and then edit this on the basis of either papers or your own knowledge to build for your population of interest these digital twins. So the barrier is very low now, I would say.
Great, thanks. That's very clear. So, quick question from Jose, which is about the comparison between the digital twin approach and conventional systems dynamic modeling. And I think he's suggesting it's partly to do with less propensity to error, ability to incorporate new knowledge, and speed. Is that right?
I completely agree with Jose. This is why we like a lot these hybrid models. So if you are in a fortunate setting where you do have such a mechanistic model, then this is great because you indeed are, you can use the large language model on top of this knowledge that you have, and that will indeed be more interpretable, it will have lower error, you can learn from less data. But very often you may not have such a high quality model. In many settings you may not, in which case it is even better to just start with large language model directly. However, I can tell you from my experience in pharmacology, if there is a high quality pharmacological model, or for that matter physiological model, then this could be a very good begin to use as a hybrid model with a large language model. But if you
Okay.
don't have it, then you start directly with the large language model and the data and
Okay.
your partial knowledge.
Okay. I'm trying to skim through these questions quickly. So, Sarah is asking a question about what kind of data you need to do a digital twin if you're thinking about
This is a
intervention.
very good and tricky question. So it depends. Ideally, the more data, the better. So you may have data about the system you want to understand or generate and simulate. So you may want to have info if your system is, let's say, a patient cohort, you may want to have information about these patients possibly under different types of interventions. Is on the other hand, you want to build a digital twin of the hospital, let's say in Cambridge, then what you may want is data about how the operational side, the logistic side of the hospital works. How many patients, what the patient workflow, and so on. And if you are interested in COVID type interventions, then of course, what you want is rates of proliferation of disease and infection rates and things like that. So it really depends. But what is very nice about large language models is partially because they've seen a lot of publications, a lot of data. They've been trained on the basis of a lot of data. At times, what's interesting is you may just need to use limited data that you have that's pertinent to what you are interested in, but the models themselves will capitalize on what they have learned from other data. So you may not need as much data as you believe.
Okay. Karina asks, how long does it take to develop a model? So I guess that's how long's a piece of string.
Yeah, so that's another tricky question. So I think it depends on, I would say, so we are building right now one in our own lab together with a quite big cohort. And we have a very experienced cardiologist that is building it with us and a machine learning student that also understands medicine. And it's going very rapidly, but I think it depends on the complexity of the problem you have and how much familiarity you have with working with these large language models.
Okay. You're picking, choosing questions quickly. What do you think about digital twins for rare diseases when there's sparse data?
I'm very encouraged by that. So there is recent work by one former student in my lab, Nabil Sidat, who was very interested in looking at how can we use this type of large language models in settings where we have very limited data. And the work is called curated large language models. And it shows that if you have the right type of minimum data, you can use that to kind of build such models. So I'm hopeful about rare diseases or data where or settings where we have limited patients. Yeah.
Mm.
Also, I see a question that's very interesting there about knowledge graphs. So
Mm.
the answer is yes. The type of knowledge that CalMDT can use could come not only from these dynamical system models or PKPD model or SER models, but also from knowledge graphs. So you can have knowledge graphs with large language models cooperating together. So the prior knowledge could come from a knowledge graph. So yes, very, very good point.
Okay. And maybe because the hour is up, maybe one final one about your summer school, actually. So somebody's asking,
Virtual, it's
is it
completely
it's
virtual.
all virtual? Okay.
It's all virtual because we try really to bring this to as many people as we possibly can.
Okay. Well, I think if it's okay, we have other questions. I'm sure people know how to reach you, and I'm sure you'd be happy
I'll be
to
very
answer.
happy to.
And could I, like, on behalf of all the attendees, and we had a lot of people joining us this morning, thank you very much for your talk. It was really tremendous and
Thanks a lot.
generated a lot of interest, and I'm sure we will be hearing a lot more about this topic in the future. So thanks very
Thanks a
much, and
lot.
thanks everybody for attending.
Thank you very much.
Okay, bye.